structure of the wall of the tube in reference to our template, our general plan of the alimentary tract. So we finished out with mouth, doing salivary glands yesterday. So when we talk about mucosa, what would the mucosa of the mouth be formed of? Remember, epithelium and connective tissue. So before we get to pharynx, let's just go back and redo that. So for the mouth, the mucosal epithelium is what?
Non-cornified.
Non-cornified stratified squamous. And obviously we have our loose irregular connective tissue associated with that. Would there be a muscularis mucosa?
Yes.
No.
No?
We never see a muscularis mucosa unless we also have smooth muscle. And so the mouth and the pharynx and the upper third of the esophagus do not demonstrate smooth muscle. Okay?
I got it in my notes from yesterday.
Well, that's the template we went through. That's the general pattern. And now as we go through each of these organs, we're going to modify that. Okay? So that template is really based on the small intestine. So that's the overall template. And now as we look at the mouth and we look at the stomach, we're going to make changes to that. We're going to remove or add things to it. Okay? Right. I mean, it's based on the small intestine. And then we're going to modify it. Okay? So no muscularis mucosa. And we're going to change our epithelia is different too, because remember we said in our template it was going to be one or the other. So no muscularis mucosa. Alright, then we have the submucosa. And what did I say the submucosa was in our template? Just dense, irregular connective tissue. So that's what we have here. And so when that's the case, I'm just going to write standard. We're not making any modifications to it. We don't have any additional glands. We have the salivary glands, but they're really not truly in the submucosa, so our standard submucosa. The third layer is the muscularis externa, which in our template we described as an intercircular outer longitudinal layer of smooth muscle. It's not smooth muscle at all in the mouth. All right, so in the mouth, we have skeletal muscle. And this would be the skeletal muscle that forms the structure of your mouth. So anyone remember the muscle that forms the floor of the mouth? Between the hyoid and the mandible, mylohyoid. That fills in, you may not have learned it in 430. We have buccinator and masseter forming the sides, okay? So that's kind of essentially what replaces our intercircular and outer longitudinal. And then what would our serosa, what would replace the serosa? We certainly don't have a peritoneum when we're talking about the mouth. So what would be the outer encompassing tissue of the mouth? Skin, exactly right. Now as we move from mouth into the pharynx, remember the muscles of the pharynx are the constrictor muscles. So everything up here is going to be pretty much the same for the pharynx. So pharynx is going to be lined with a non-cornified stratified squamous, loose irregular connective tissue, no muscularis mucosa, submucosa standard. Muscularis externa is still skeletal muscle, and it would be the constrictor muscles. And then I suppose you could say the skin, but we have something a little bit closer that envelops the pharynx. And we use a term that was one of the alternate terms for the outer connective tissue covering of our blood vessels. Remember we had the tunica intima, and then we had tunica media and tunica externa. And what was another name for the tunica externa? Adventitia. All right, so it's collagen fibers, dense irregular collagen fibers around the outside of the pharynx. We'll see it again with the esophagus that just attach the esophagus to the posterior wall of the trachea and to the bodies of the vertebrae. Okay, so for the pharynx, then everything up here is going to be the same, except we call the outer covering an adventitia instead of a serosa. and that's a dense, irregular connective tissue. And we see this is going to continue in our esophagus, except that the esophagus transitions to smooth muscle. And so we see some changes in the esophagus as that occurs. As we essentially have three regions of the esophagus. The upper third is identical to the pharynx, and it's in the middle third that we start to see this transition. Okay? So although much of that is going to be the same, if you don't mind, if you're ready, I'll erase what I have up there, and we'll look at the esophagus. Okay? Just looking around the room. You're the only one that will make eye contact with me. So, esophagus. Our mucosa. Still non-cornified. Stratified squamous. Still a loose, irregular connective tissue. Now the muscularis mucosa. All right, remember I said we divide the esophagus into three regions. In that middle third is where we start to see smooth muscle. So it's also in that middle third that we start to see the muscularis mucosa. That 1 to 2 layers of smooth muscle that separates mucosa from submucosa. So we will put in a muscularis mucosa here.
Before the submucosa?
Yes, because the muscularis mucosa is part of the mucosa. We don't see it's like the distal 2/3. We really pick it up in the lower half. Okay? So the distal 2/3 to 1/2 of the esophagus. In other words, if I were to diagram the esophagus here, we would start to see muscularis mucosa kind of patchy here, and then at this area like that. That's where we pick up. Because that's the pattern that we start to see picking up the smooth muscle.
So the muscularis mucosa is the same as the muscularis externa?
No.
Because it says it starts at
The muscularis externa,
it says the first of the skeletal muscle.
oh, that's muscularis externa.
Okay.
But muscularis mucosa is part of the esophagus. I'm sorry, it's part of the mucosa. All right, then our submucosa is standard except for, remember what I said about the submucosa
Has a gland.
yesterday when I was doing the template?
It has the submucosa gland.
Exactly. So standard except we add submucosal glands. In the last 1.5 inches or so, the esophagus passes through the diaphragm, and actually much closer than that because it's a very tiny esophagus. Passes through the diaphragm, and that last 1.5 or 2 inches of the esophagus is going to have mucosal glands. These are not goblet cells, all right? They're kind of like the mucus glands that we saw in the submandibular and sublingual salivary glands. And they secrete a mucin proteinaceous material that travels through a duct to the surface of the esophagus and protects against acid reflux, splashing up of gastric juices onto the lining of the esophagus. Now we get to the muscularis externa.
Where I was jumping.
Yes. And this is where we see most visibly the transition between our mouth region and the rest of our stomach region, the rest of our gut region. So the proximal 1/3, or the upper 1/3, is skeletal muscle.
much voluntary control over that though, all right? The skeletal muscle of our breathing, we can stop and start, and it's kind of a reflex. Once you're swallowing food and it's down into the esophagus, it's really difficult to stop it at that point, even in the lower pharynx, all right? In the middle 1/3, we still have skeletal muscle, but now we're adding smooth muscle. And the more smooth muscle we add, and the less skeletal muscle we have, the easier it is to see the muscularis mucosa. So those going to go together. And then the distal third is only smooth muscle. And this is now in that inner circular, outer longitudinal pattern that I illustrated with the template. And I abbreviate inner circular IC, outer longitudinal OL. So the sphincter, the cells are oriented the long length of the cell, a circular pattern around the tube, and then outside of that, the longitudinal muscles are illustrated a length.
I'm gonna look at that note tomorrow and not know what the hell I see means.
Well, write it out then, because I'm going to use it several times today.
And before that, is there a pattern for that?
For the skeletal muscle,
For the smooth muscle?
for the smooth muscle, it's hard to find. I mean, starting in that pattern. And then finally, we don't have a serosa. Well, let me rephrase that. We only have a serosa for that part of the stomach that has passed through the diaphragm that's actually in the abdominal cavity. So instead of a serosa, just like we saw with the pharynx, this is an adventitia. Because there's no epithelia. So it's just a dense, irregular connective tissue. All right, well, we'll probably start a little bit of physiology Tuesday, and then finish it on Thursday. And at that time, we're going to cover the innervation, but just to get your brain a little more awake and exercise. What would be the parasympathetic innervation of the esophagus? What's the parasympathetic nerve of the entire thoracic cavity?
Vegas.
Vagus.
I was gonna say that I was drinking. My bad.
I'm sorry. Shouldn't have asked a question, just as you picked up your water. So when we look at the models of the torsos in the back of the room, they're actually modeled to have the plexus of the vagus nerve wrapped around the esophagus. And in the cadaver, we're going to take an opportunity to look at Tom's digestive system again next Thursday. And you'll be able to see the esophageal plexus as it wraps around the esophagus after branches are given off to the heart. All right, so the esophagus is really just a connection between the pharynx, mouth, and stomach. No enzymes are added here. The only glands that we have are the submucosal glands. And so the only digestion that's going to take place is what started in the mouth and continues before it actually gets to the stomach.
Doesn't look like it takes very long to get in.
And it doesn't. So there is a condition where the esophagus is narrowed, restricted, or entirely disappears. Not disappears, but never has a connection, separates that connection with the stomach. This is a congenital condition, so babies are born with it. And the first sign is something called projectile vomiting, where the baby nurses or drinks the formula, and then a few minutes later they're throwing up 10 feet across the room. If it is a blind pouch like this, they'll put a gastric tube in until surgery can be done to add some type of prosthetic esophagus. If it's like this, it depends. They'll make a measurement. See the baby, and then, yes.
I just did that a couple days ago. The first little girl had one from her own stem cells.
Oh, really?
Yeah, and it was like 2 days ago. She was able to breathe and swallow through it. She's only a couple years old, but she's the first one in history that actually use stem cells of her own.
Our own stem cells to do it. I
Usually-
wasn't even aware they were treating it with stem cells, because when my 16-year-old son was an infant, he was 7 months old when he had his, remember I said he was born with his mouth open to here, so he was 7 months old when we went in and had that repaired. And there was a discharge in his room shortly after he got up to his room in the peds ward, and the new patient was a newborn who was less than a week old and had been diagnosed with esophageal atresia. If it's narrow enough at the time, the surgery at that time, this was 97, was to go in and place a stent that would stretch out the wall of the esophagus. Now, was she missing an esophagus and they're replacing it with stem cells? Okay, cool. And so if it's wide enough and they don't feel that stent is necessary, then they'll just, she can only take liquids and stuff. Otherwise, they'll place a stent in. When he came back about 8 months later to have his nasopharyngeal tonsils taken out, in the waiting room with us was a family whose son was about 3 and had already had about 4 or 5 of those surgeries. He just had to keep going back in and continuing to stretch the diameter of the esophagus. Now let's move to the stomach. So now we're actually going to be within the peritoneal cavity. So only that last 1.5 inches or so that you see right here of the esophagus is going to be intraperitoneal. The rest of the esophagus, which is in the thoracic cavity, is neither, because it's not in the abdominal cavity. If it's not in the abdominal cavity, it can't be intraperitoneal and it can't be retroperitoneal, because it's not anywhere around the peritoneum. Okay? But that part of the esophagus that is inferior to the diaphragm is intraperitoneal. There is an actual opening within the diaphragm for the esophagus. The aorta, the diaphragm kind of forms a U over it. Nearby is an opening for the inferior vena cava, and this area can be weakened. We talked about the inguinal hernia. And this area of the diaphragm that is weakened is known as a hiatal hernia. Talking about interesting surgeries. Infants, new fetuses can develop a hiatal hernia before birth. And the stomach and part of the small intestines can move up into the thoracic cavity, and that affects development of the lung and heart. So if the lung is compressed up, it's not going to develop the hollow air spaces, it's going to develop solid tissue, and these babies have a 100% mortality rate unless something is done. So about the late 1990s, early 2000, a procedure was developed in San Francisco, the first type of procedure to actually do surgery on a fetus that wasn't in utero. They would go in and do blood transfusions and stuff, and go through the uterus with their laparoscopic instruments, and through the amnion. In this procedure, they actually opened up the uterus, opened up the amniotic sac, took the fetus out of the uterus, and placed it near, right next by on an operating pad, if you will. Opened up the fetus, patched the hole with a loop and hook, a Velcro type tissue, and then put the fetus back in the the amniotic cavity, added saline, stitched the amniotic membrane back together, and the uterine wall back together, and the abdominal wall of the mother back together. Obviously, she couldn't have a vaginal delivery. The tissue would not have healed. And so a C-section was performed. And that gave the fetus about, over the next 5 or 6 years that I was reading about it, about a 50% chance of being born alive, which was better than the 100% mortality. So it'd be interesting to look up and see on the fetal cell, the stem cell thing, what they're using it. That was just an anecdote part there. All right, so let's look now at the depth.
Were you saying the part of the esophagus below the diaphragm?
I'm going to diagram it on the board. So the esophagus above the diaphragm in the thoracic cavity is not associated with pleura, it's not associated with peritoneum, so that's the adventitia. All right? But if we look at the diaphragm, and here's the esophagus coming through. Let me draw my study a little bit bigger than that. Then it's going to pick up peritoneum on the inferior diaphragm, and then visceral peritoneum on that region of the esophagus. So just that lower part that we see in the peritoneal cavity, or in the abdominal cavity is going to have peritoneum on it.
And that, you don't have the adventitia, you're saying?
Well, this would be visceral peritoneum here, in the thoracic cavity would be adventitia. All right, let's just identify some of the regions of the stomach. So this area that I'm kind of encircling with a dotted line, where the esophagus attaches to the stomach, there is a thickening of smooth muscle, creating our second sphincter.
I was a little.
Okay. And this region is known as the cardiac. So kind of this area right here around the stomach is known as the cardiac. And that gives rise to the most simple form of the name of this sphincter, which is the cardiac sphincter. It's also known as the gastroesophageal sphincter, in other words, the two organs. And you see that term here. Okay? But either one works.
So you can't use the esophagus sphincter?
Yeah. Not just esophageal, but gastroesophageal.